Good afternoon, everyone, and thank you so much for joining us again for this week's APPs in Urology Symposium installment. We have a fantastic lecture for you today by Kerry Paulson. She's going to be talking to us about prostate cancer and active surveillance. Before I get started, a couple of housekeeping things. Thank you all for participating with us over our series. We have today's webinar and next week's webinar as the final two within this first series, and then we're going to take a hiatus for the remainder of the summer and then come back in the fall with a goal of hosting monthly webinars. So keep your eyes peeled for information about how to register, sign up for those, tell all your friends. We are, in order to get that information, you can follow me on Twitter at EuroPA_SD, or you can follow at UCSD_urology for more information. You can also follow us on our APP Symposium YouTube channel. And so that link is going to go out via email and on social media later this afternoon, but you can also go to YouTube and search APP Symposium. Don't forget to subscribe to us so that you can get push notifications for any new uploads, and also so that we can continue to grow our base of supporters. So without further, before I go on, sorry, last thing, questions, we will take questions. You can go ahead and submit questions throughout the webinar today. We're going to take questions at the end, but you can use the little Q&A button at the bottom of the screen to submit your questions, and then we'll save them until the very end. But go ahead and submit them anytime throughout the webinar so that you don't forget and so that we can discuss them at the end of the webinar. All right, so to introduce Kerry Paulson, DNP, is a certified adult nurse practitioner and women's health nurse practitioner who cares for people with urologic cancers with an emphasis on long-term cancer survivorship care, wellness, and patient education. Her scope of care includes physical evaluations, diagnosis, treatment, symptom management, and supportive care for both new and returning patients. Prior to joining UC San Diego Health Urology Department in 2017, Kerry worked as a nurse practitioner in St. Paul, Minnesota, Orange County, California, and San Diego, seeing men and women of all ages. She has over 24 years of nursing experience, providing care to patients and their families in clinic, hospital, and community settings. Kerry obtained her doctorate degree in nursing practice from the University of Minnesota School of Nursing in Minneapolis. She earned her bachelor's degree in nursing from Winona State University in Winona, Minnesota. She is a member of the California Association of Nurse Practitioners and the American Urological Association. Kerry admits she would have never predicted she would end up working in urology, caring for men and women with cancer and other urological issues. She also admits she wouldn't have it any other way. When she is not working, Kerry enjoys spending time with her husband and two teenage boys who have suddenly outranked her in height. So go ahead, Kerry, take it away.
Well, great. Hello, my fellow urology colleagues. Thank you, Rachel, for the introduction. It's my pleasure to be with you today to talk with you about prostate cancer and the role of the APPs when caring for men who are in active surveillance. I have no disclosures. My objectives for today's presentation will briefly provide an overview of the epidemiology of prostate cancer, a review of the basics of male urogenital anatomy, the definitions of low, intermediate, and high-risk prostate cancer, along with the definitions of active surveillance and watchful waiting. Then I will turn to the natural history of prostate cancer, how we know active surveillance is safe, and how the AUA supports APPs in the care of the patient with prostate cancer. I will cover the NCCN criteria and principles of active surveillance, and when to evaluate further or stop active surveillance altogether and proceed to treatment. And finally, I'll provide an example of an active surveillance protocol here at UCSD and some tips for a successful APP active surveillance program. I look forward to any questions you may have at the end of my presentation. So a brief overview of prostate cancer epidemiology. It has a pretty high relative 5-year survival rate. 97.8% of men with prostate cancer were still living after 5 years. 12.1% of all men will be diagnosed in their lifetime, making it the most common cancer in men in the United States. It affects African Americans more than Caucasians, and Asian men are the least likely to have prostate cancer. Most men who are diagnosed are over the age of 50, and studies have shown that over 70% of men will have prostate cancer by the time they're 80, making it often considered a normal variant of aging. The prostate gland, so some basics on the anatomy. It's a walnut-shaped organ that you can see sits below the bladder and wraps around the urethra like a donut. There are 2 seminal vesicles that sit behind it and are directly linked to the prostate gland. The prostate secretions are a main ingredient in seminal fluid. The prostate itself is contained in a capsule and flanked by neurovascular bundles on each side, and those contribute largely to sexual function. The normal size is 30 cubic centimeters. Looking over here at the prostate anatomy, the majority of prostate tumors tend to develop in the peripheral zone, which is right here. Urethra. Cancer tumors are less often in the transition zone. We also have the central zone, which is right linked to the seminal vesicles. I do also want to point out, here's the anterior prostate. If you look, that is typically pretty challenging to attain on biopsy. Not challenging to attain, but sometimes if there are tumors in the anterior prostate, those can easily be missed when we do transrectal approach. Okay, so there are 3 types of prostate cancer: low, intermediate, and high risk. When the pathologist looks at the tissue under the microscope, he or she identifies the cell pattern type and then identifies the primary pattern and the secondary pattern, which then makes up the Gleason score. Pattern 2 is no longer used when establishing a Gleason score for prostate cancer. Pattern 3 is biologically considered very similar to normal cells and has a low or very low to no capacity to metastasize. Pattern 4 and 5 are considered more aggressive and both have the capacity to metastasize. Low-risk prostate cancer consists of Gleason 3+3 or grade group 1 out of 5, which is another classification. Intermediate risk is broken down into favorable and unfavorable intermediate risk. Favorable risk is Gleason 3+4. The majority is pattern 3, and a smaller portion is pattern 4. And the opposite is true for unfavorable intermediate risk, Gleason 4+3, where the primary pattern or the majority is pattern 4. So the remainder risks are high-risk types and are sequentially listed, you'll see. The majority of today's talk will be focusing on low-risk and intermediate-risk prostate cancer. Okay, so prostate cancer MRI prostate results. For a basic overview of the multiparametric MRI, results are reported out by the reading radiologist using an international assessment reporting system. The rating system was first published in 2012 and version 2 was later published in 2014, so it's been around for a little while. For the purpose of this, clinically significant represents any Gleason score greater than 7. You'll look and see PIRADS 1 and 2 are considered essentially negative or normal. Tissues are normal appearing and no lesions are identified. PIRADS 3 is intermediate between normal and abnormal. Results are equivocal. PIRADS 4 and 5 are both abnormal, and there's a high likelihood of prostate cancer in PIRADS 4 and 5 lesions, specifically 86% chance of clinically significant cancer with PIRADS 4, and 93% chance of clinically significant cancer with PIRADS 5 lesions. Sorry about that. Okay, so prostate cancer staging. T1, prostate cancer cannot be palpated. It's confirmed by biopsy and localized, clinically localized. And T2, which is a tumor that can be felt on the rectal exam, remains localized and is on biopsy either on one side or both. Any man with T3 or higher disease does not qualify for active surveillance because it's already extended outside of the prostate capsule as with T3 or spread to other organs as with T4. Let's talk about the similarities and differences between, oh, excuse me, one more. Oh, it's bouncing. I'm not sure why. Technical difficulties. Thanks for your patience. Well, for some reason, this slide is skipping and I can't get it to stay. All right. We're going to skip the difference between active surveillance and watchful waiting today, but I do want to say, I can just verbally tell you that active surveillance is technically, both of them are monitored. Watchful waiting and active surveillance, men are both monitored closely. The difference is active surveillance, if there's evidence of progression, we proceed to treatment because we know that proceeding to treatment, there's still a possibility of curative intent. And with watchful waiting, typically that is supported for men who have a less than 5-year life expectancy. And if there's evidence of progression, we're going to intervene to provide comfort and support for the symptoms that arise. So now that we're on the slide that wants to stay on that slide, excuse me. How do we know that it's safe to monitor men with low risk prostate cancer? Shouldn't we be treating any and all men who have cancer as soon as possible? Well, a group in the UK published a randomized controlled trial in 2016. They recruited 1,643 men ages 50 to 69 with clinically localized prostate cancer. And they compared treatment with either surgery or radiation versus active surveillance. The study's primary endpoint was prostate cancer-specific mortality, more specifically their 10-year survival rate. And you'll see when comparing the three options, there was very little difference. Further proving the safety of active surveillance, there are 2 additional studies I want to talk about. In a study by Egners published in 2011 in the Journal of Urology, this study looked at 9,500 men with Gleason 6 prostate cancer treated with surgery, and their 20-year follow-up showed 0.2% to 1.2% prostate cancer mortality. And a review of those cases showed higher grade disease. Another study by Ross, published in 2012 in the American Journal of Surgical Pathology, looked at 14,123 men with Gleason 6 who also were treated with radical prostatectomy. 0.002% of men had evidence of cancer in the lymph nodes. Again, re-review demonstrated higher grade disease. So these 2 large volume, well-respected studies provide evidence and support that Gleason 6 prostate cancer, when confirmed, tends to remain indolent and therefore is safe to monitor, thereby avoiding overtreatment. How about the safety of APPs and having APPs provide oversight for men with low-risk prostate cancer? A retrospective analysis at Memorial Sloan Kettering was conducted to compare outcomes between APPs and MDs. There were 155 APPs and 1,400 MDs. The outcomes assessed were prostate biopsy complications, no-show rates for biopsy procedures, and cancer progression between groups. Between 2000 and 2019, 2,341 patients had active surveillance follow-up visits, with 1,300 of them having biopsies. The biopsy complication rates were low, with up to 1.5% of infectious complications and only 1 documented case attributed to an APP. So overall, no difference between the 2 providers. Another interesting finding was no meaningful differences between no-show visits when comparing visits by APPs and those by the urologist, indicating patient acceptance of APPs performing biopsies. And finally, and also very importantly, there was no significant difference in cancer progression between the doctor and APP groups. So this particular analysis demonstrates that with adequate education, training, and physician mentorship, APPs can provide a valuable service to patients and to healthcare institutions. The AUA encourages the use of APPs in the specialty of urology. In 2014, over 10 months, a diverse group of physicians and APPs got together and drafted a consensus statement promoting the integration of APPs. The statement reads, in a team-based approach with a board-certified urologist in a supervisory role, allied health personnel contribute to the care of the patient with genitourinary disease, and therefore the AUA encourages the proper use of allied health personnel. Well, obviously, if a lot of us are here or APPs, this has been true for a little while, but I also just want to accentuate the fact that AUA has actually written a consensus statement about it. Okay, so the NCCN has delineated each risk type with specific criteria for active surveillance. You will notice that low risk is actually divided into very low risk and low risk. And they each require the PSA to be less than 10, involve only grade group 1 or Gleason 3+3, be clinical stage 1 or not palpable for very low risk, and low risk can involve a palpable nodule on one lobe of the prostate only. And both suggest that the PSA density should be less than 0.15. The difference in very low risk prostate cancer is that the volume of disease is very low, just 1 or 2 cores in biopsy, and no cores are over 50%. And then you'll see that favorable intermediate risk prostate cancer is somewhat of a gray zone. It can involve grade group 1 or grade group 2, and less than 50% of the cores are positive on biopsy. Plus, one of the intermediate risk factors, PSA 10 to 20 or grade group 2 or 3, which grade group 3 is Gleason 4+3, or the palpable tumor, which is still localized, can be in both sides of the prostate. I do want to point out that if a patient is reluctant to pursue treatment, he can be offered what is considered extended active surveillance, which essentially means it is a matter of when, not a matter of if he will be treated. It's buying some time until treatment with close supervision and with full understanding of the risks involved. I will add, in our practice, it is very rare, if ever, that patients will go on extended active surveillance with grade group 3 specifically. There are definitely times when active surveillance is not appropriate. Briefly outlined here, grade groups 3, 4, and 5, and you'll see again, grade group 3 is listed there, but it's also listed in the intermediate risk option. They're the gray zone. Those with high risk features on biopsy, namely intraductal carcinoma, sarcomatoid features, small cell carcinoma, and cribriform pattern. African American men, while they're not to be excluded from active surveillance, it is important to counsel them that they are at increased risk of cancer progression and therefore should be more rigorously monitored. Those with high volume of cores on biopsy, also translated as having more than 50% of cores positive, and the PSA over 20. I will add, when a PSA gets close to 10, it is important to pursue additional testing, and that is either an MRI or repeat biopsy, and we'll talk about that. The NCCN has provided guidance in the form of some principles of active surveillance. Just one second here. Men with very low risk prostate cancer with a greater than 20-year life expectancy should be offered active surveillance. Men with low risk prostate cancer with greater than 10-year life expectancy should be offered active surveillance. Men with favorable intermediate risk prostate cancer can consider active surveillance. Men with low risk prostate cancer with a less than 10-year life expectancy should be observed, watchful waiting, and consider confirmatory biopsy with or without MRI to confirm active surveillance is the appropriate strategy. I lost my ability to advance the slide. Perform the DRE no more often than every 12 months unless clinically indicated. Check PSA no more often than every 6 months unless clinically indicated. Repeat MRI no more often than every 12 months unless clinically indicated. Repeat biopsies are no longer indicated for men with a life expectancy of less than 10 years. And finally, a repeat biopsy should be considered if prostate exam changes, MRI suggests more aggressive disease, or PSA increases, but no parameter is very reliable for detecting cancer progression. There are thresholds for additional evaluation. When should we further assess? They include rising PSA density to greater than 0.15. By the way, PSA density is PSA divided by the volume of the prostate gland. And changes in exam findings. If it has been at least a year, the recommendation is MRI of the prostate and biopsy pending the results. Evidence of progression on prostate MRI includes increase in volume of the index lesion, increase in the PI-RADS score, and new lesions. Any of these observations should then lead to repeat biopsy. Evidence of progression on prostate biopsy includes an increase in Gleason's score and an increase in the number of positive cores, or evidence of larger volume of disease. These findings should then lead to treatment. Here's a diagram depicting how we monitor men on active surveillance at UCSD. A man with a positive biopsy who meets criteria begins active surveillance with 6 months clinic visits. A confirmatory biopsy with or without a prostate MRI takes place within 12 to 18 months of initial diagnosis, and this confirms if active surveillance is the right strategy. If it confirms low risk, low volume prostate cancer, then active surveillance begins with PSA and rectal exam every 6 months, and thresholds for additional evaluation to include rising PSA, changes in exam, and rising PSA density. If the confirmatory biopsy shows higher volume of disease or higher Gleason score, the patient is advised to proceed to treatment. Likewise, if during active surveillance, if the repeat MRI and biopsy combined demonstrate progression of the cancer, the patient is advised to proceed to treatment. If stability is confirmed, the patient continues active surveillance with PSA and rectal exam every 6 months. If all stable, the repeat MRI is obtained every 3 years and the biopsy every 4 years at the latest. And finally, I'd like to offer some tips and suggestions for a successful APP active surveillance practice. So I found it helpful to have 10 months of shared visits between myself and the attending physician I work with. Seeing a variety of prostate cancer scenarios helped me to fully grasp and apply the guidelines. I met several patients who would eventually transition into my practice. Having already established some connection with me helped to facilitate trust for the patients. And also that time built in clinic with the physician built mutual trust between myself and the physician, which is essential for both parties involved. It's a good idea to schedule regular meetings, and we meet weekly to discuss case discussions. There are times when cases are more complex or a patient scenario is borderline, and if there's a question or a need for affirmation, patients appreciate knowing that the physician has spoken into their care. When a patient comes to see the attending physician and is deemed appropriate for active surveillance, it's important for the physician to introduce the APP with high regard. For example, this is so-and-so, he or she works with me and is an integral part of our cancer team. I fully trust her and him to carefully monitor you. We meet on a regular basis, and he or she will keep me up to date on any concerns along the way. I suggest considering alternating every other visit between the APP and MD. This isn't a requirement, and we don't always do that, but you may intuit that some patients will appreciate it. I have had other patients who feel their stable status can stay with me, as in, if I have to see the doctor, that means things are not going well, or they understand this allows the doctor to see more complex cases. Some patients do understand that. And finally, consider having the APP provide all the MRI and biopsy results to the patients. I found that these are in-depth and personal discussions with a lot of teaching and establishing trust and relationship with the patients. And if they're eligible for active surveillance, they move right into our shared practice and they usually see me. So in summary, prostate cancer is a common cancer among men with a high 5-year survival rate. Active surveillance is a safe strategy for men with very low risk, and intermediate favorable risk. The AUA and the NCCN provide effective guidelines for the management of men on active surveillance, and the AUA supports APP practice in urology. The APP has an excellent opportunity for independent practice in partnership with urologists. These are my references, and time for questions.
Thank you so much, Kerry. That was excellent, and provided a lot of really great information on who qualifies for active surveillance. That was wonderful. So anybody who has any questions, please feel free to use the Q&A at the bottom, and we'll get started. So one question about the UCSD protocol for active surveillance and sort of the way that you follow it. The one question I had was about if the MRI at 3 years per se, so after you've determined everyone is stable, someone is stable on active surveillance in after the second biopsy, confirmatory biopsy in 12 to 18 months, at that 3-year mark, if their MRI has shown no changes, would there still be another biopsy no later than 4 years?
Yes, yes, we have continued to do the biopsy at 4 years. Yes.
Okay. Okay. And then next question is, let's see, this question is, how do you follow patients with ASAP on initial biopsy?
Great question. Generally speaking, I mean, I don't see a lot of that. I will say we would consider if they had no cancer confirmed on biopsy, we would probably put them in a bit of a higher potential by evaluating them with more rigorous PSA intervals, maybe every 6 months instead of every year.
Great. Does your active surveillance protocol include any ancillary testing, whether it's like 4K score or any of these other urine or blood tests that help differentiate patients in terms of their risk?
There have been times that we have utilized that. It's definitely not on a routine basis. But there are times when it has been useful if there's like a tiebreaker. We need a tiebreaker to really affirm that active surveillance is the right strategy. So yes, we do use them, but it's not written into our protocol as a standard. Excellent question.
Okay, good. Wonderful. Let's see. What are some of the ways that you counsel patients? This is before they're diagnosed with prostate cancer, but the patient who has the elevated PSA, in terms of their discussion, patients are often really concerned about treatment for prostate cancer. What are some of the things that you might say to them in terms of counseling them on, well, here are, just because you have prostate cancer, sometimes patients are allowed for active surveillance, sometimes watchful waiting. What are some of the things that you start to counsel patients on when they're presenting to you with elevated PSA, but concerns about biopsy and moving forward with treatment?
That's a good question. Are you asking specifically someone who really looks most likely to have prostate cancer based on the various clinical information we have on them, or just, okay. I do a lot of explanation of the PSA, the specifics about PSA, how non-specific, I should say, it really is, that there are several reasons that we can, that cause an elevated PSA. I encourage an MRI if necessary, so that we can get more information. And if the MRI looks like there's an obvious lesion, of course, we're going to proceed to biopsy. I usually don't get into prostate cancer per se as much when there isn't a full-on diagnosis. I do explain we've got low-risk types. It may be a low-risk type. some men, it's a common normal variant of aging. It's a very common cancer diagnosis for men, particularly in the United States. But I have started to use, and we do sometimes use some of the resources out there for biomarkers and things like that that further help us risk stratify when it would be appropriate to do a biopsy. I hope that answers your question.
Yeah, no, that's super helpful. That's exactly where I was going.
Okay.
Okay, so we have someone who says, thank you so much for your lecture. So what are some of your favorite life expectancy calculators? And thinking about transition from active surveillance to watchful waiting, what are some of the factors that you use to guide that?
Excellent question. Honestly, I have not used a life expectancy calculator. If anybody wants to mention one to me, that would be helpful. A lot of it has just been based on my my clinical judgment and the comorbidities, et cetera. Rachel, can you repeat the end part of that question?
So then in your experience, without using a calculator, do you transition, the question is thinking about how you transition from active surveillance to watchful waiting. What are some of the factors you use to guide that in your own practice?
A lot of it is the NCCN principles and considering, the clinical picture. This is, for example, a gentleman who is now 80 years old, has been on active surveillance for 15 years, has each subsequent biopsy has proven, if there's maybe a couple biopsies, has proven, low risk prostate cancer. I essentially say, hey, we're not turning our eyes away from you. Your life still matters. You still have life ahead of you, but we don't need to be aggressive in looking for aggressive cancer. We can keep an eye on you with PSA. And certainly if there is some concern, we'll address it. But I just really try to encourage that, we can simmer down on the assessment techniques now that your cancer has shown to remain pretty indolent. So
that's a really nice way of saying it. Your life still matters. I think that from somebody who doesn't treat prostate cancer, but someone who helps manage patients through the elevated PSA evaluation process, that discussion, especially for those patients between ages of 70 and 80, it often turns into a accepting of someone's own mortality, which is a really difficult discussion to have. So I like that way of saying it. That's interesting. Okay, so next question is, when do you recommend saturation biopsy versus an in-office transrectal ultrasound prostate biopsy? So I think she's talking about like a perineal biopsy.
Yes, gosh, we've had again, it's been 3 years with me here. We've had a couple of those, and we've had a numerous transperineal, but when I think of saturation, I think of more than 15 cores. That they were really, we've had patients with MRIs that show abnormalities and PSAs that are getting up to 17, 18, 19, 20, but their biopsies are negative. Definitely transperineal approach under anesthesia, saturation. Those are the ones where we're thinking that this might be something on the anterior surface of the prostate. There's a little something there and we have successfully achieved finding what we were not able to get on transrectal through saturation. But again, it was a rising PSA 1 or 2 negative, not negative, but unsuccessful in figuring out what it was. I don't know if they had any other low risk prostate cancer. I can't remember that specifically, but again, it's PSA continuing to climb in the teens.
So high index of suspicion without a good answer.
Right.
Awesome.
Exactly.
Well, thank you. Again, excellent lecture, really helpful in terms of understanding how APPs can be pioneers sometimes too in the field of active surveillance. Really, thank you so much for all of that. everyone, go ahead and if you'd like to view this lecture again recorded, you can follow us on our YouTube channel. Again, go to YouTube and search for APP Symposium and click subscribe. You'll see all our symposium lectures there. We have one more lecture next week in our series on androgen deprivation therapy. In this initial offering series, we are then going to take a hiatus for the rest of the summer and come back in the fall with some monthly offerings. So stay tuned for our additional announcements on that. You can follow me at EuroPA_SD, and you can follow at UCSD_urology on Twitter for more information and to find the links for upcoming webinars and for our YouTube channel. Thank you again so much, Kerry, and looking forward to seeing all of you next week.
Pleasure.